everyone. Thank you for being here, and thank you to Pammy for that inspiring but very difficult act to follow. Hi, I'm Rachel Hall-Clifford. I'm a medical anthropologist working in global health. As a medical anthropologist, I apply the techniques of anthropology to the design and evaluation of global health programs. Anthropology is a discipline of patience. It's rooted in building deep understanding of people and places, often through the participant observation technique, which means living in and becoming a part of the communities of study. That takes time. On the other hand, global health is a field of urgency. It is a multidisciplinary field dedicated to the promotion of health and the reduction of health inequalities. For that, there is never enough time. Both fields are rooted in the colonialist enterprise, and they struggle to overcome the inequalities that continues to perpetuate. So I'd like to think together about how Codesign can promote equity in global health. Over my career, I've had the opportunity to live in many rural Mayan communities in the Central Highlands of Guatemala. They're beautiful. In one small village where I was living, as I got to know the local landscape, I began to realize that I was looking at the failures of global health. There were yellowed and crumpled health education brochures and posters left behind by a potpourri of NGOs. There was the broken water pump in the center of the village that had been delivered by the government but not maintained by them. The list went on and on. I realized the village was a global health junkyard. I also began to see that those failures of global health placed additional burdens on the backs of community members who were still struggling to access health services. The Indigenous Maya community were positioned simultaneously both as objects for pity and empowerment. Their historical marginalization, isolation, and poverty, making them check all the boxes off on the ideal global health target population. Within communities, global health seeks to serve the population where they are. This doesn't always happen. One afternoon, I tagged along with a Guatemalan Ministry of Health colleague of mine to a meeting in Guatemala City convened by an international aid agency. The purpose of the meeting was to get progress reports on a nutritional supplementation program designed to improve the health and the growth of children in the Central Highlands. The foreign coordinator called the meeting to order, and then each local, regional implementation manager went around the room reporting in on how much nutritional supplement had been delivered and the growth statistics of children in their region. After each man, they were all men, had reported in, the foreign coordinator dropped his head into his hands and said, "Why isn't anything changing? Why isn't this working?" There were a few, murmurs and ventured suggestions, but the room got quiet quickly, and I realized I was raising my hand. I explained to the room that I was currently living in one of the villages served by the program, and that, of course, parents in that village wanted what was best for their kids. Of course, they wanted their children to grow, but they did not feed the nutritional supplement to their kids. They fed it to their chickens. There was laughter that exploded around the room, groans, and comments about the futility of implementing global health programs among the Maya communities, as though community cultural identity could or should explain their program failures. But as things quieted down again, I went on to explain that the nutritional supplement was delivered in bags that looked like feed bags. So they gave the animal feed to their animals, the chickens. No one would give their kids animal feed, but the community was delighted with the program because their chickens laid more eggs, which they could eat or sell in the market. And so the project was having nutritional outcomes, just not the ones intended by the World Food Program. I think this story shows us that sometimes global health programs miss the mark. But it also shows us the creative agency of community members. They are not empty vessels just sitting around waiting on someone to come and tell them how to live. Too often, global health programs are paternalistic in assuming that we know what is best for communities. Communities are then positioned as being liable for the successes and failures of global health programs based on notions of compliance patterned by racism and gender bias. Community autonomy is diminished when global health programs conceived in hubs like Geneva, London, Atlanta don't consider local context. We cannot develop global health programs distantly and drop them off locally and expect them to be successful. As in minoritized and marginalized communities around the world, Maya communities in Guatemala are expected to be passive recipients of global health. Like many other communities, they have also faced centuries of exclusion and violence. Guatemala experienced a recent genocide that only formally ended in 1996. This continues to shape health and health seeking. For example, I once got to ride along with a Ministry of Health team who was charged with delivering a vaccination campaign. They had very clear targets of the percentage of rural populations they had to reach with vaccine to meet their goals. So they started getting frustrated one afternoon when no one was coming out to take vaccine. They were struggling. So in their frustration, they started joking through the truck's loudspeaker, come out, get your vaccines, or we'll have the police come in and drag you out. For communities who within living memory had family members drugged from their homes never to be seen again, it wasn't funny. It reminds me of a few lines from a John Keats poem. What can I do to drive away remembrance from my eyes? Touch has a memory. Oh, say, love, say, what can I do to kill it and be free? Of course, Keats is talking about his love, and here I am talking about global health. But communities have a memory. Global health programs have a touch. And global health must not perpetuate the violence of inequality in communities around the world. Instead, we can co-design programs that prioritize community strategies and needs. So what is co-design? Co-design builds on participatory action research and agile design methods to center communities in the design, innovation, and implementation process. Co-design is a 6-step cycle that's very iterative. First, problem identification with a local partner. Second, needs assessment and asset analysis, recognizing that there are existing strengths to draw from. Third, we can build on existing innovations and existing resources. Fourth, we adapt those resources for the local context. Fifth, we train end users. So we expand the ideas of co-design outside of the co-design team. And sixth, implementation and ongoing support. Co-design is both agile and human-centered, meaning that it operates on a very rapid cycle of trial and revision. The work is never complete. Co-design can be applied to any global health intervention process, design process. But of course, we have health tech innovations that open up a whole new world of possibilities. We know that since the turn of the millennium, affordable, low-cost mobile health technologies have exploded, enabling us to leapfrog generations of legacy hardware and infrastructure in global health. This means that we can deliver disease surveillance, diagnostics, and treatment far beyond the reaches of traditional health facilities and provider networks. 86% of all humans live within reach of a mobile network and growing. The possibilities are dizzying. Yet, for all of their possibilities, the affordable health tech in global health walks the knife edge of equity. Because of entrenched elitism in research institutions, industry, and regulatory agencies, the usual suspects still dominate innovation in global health, those from high-income institutions. So I'd like to talk to you about an example of Codesign because Codesign pushes back against this power imbalance. It also pushes back against the received wisdom in global health that we can build on economies of scale that take global toolkits and deliver them locally with minimum local input. So I am excited to share the example of Safe Natal. I was a part of the co-design process of Safe Natal, a perinatal monitoring and decision support toolkit for Maya midwives, developed with and by them for use in their own rural Mayan communities in Guatemala. We know from our partner organization, Wukukawuk, the Maya Health Alliance, that women in rural Maya communities strongly prefer to give birth at home. This is both because of cultural tradition, but also because of the racism and structural violence they face when seeking facility-based care. We wanted to support that preference for home birth when safe, but also create pathways for facility-based care when it's needed. So the Safe Natal Toolkit uses existing hardware and a mobile app alongside AI algorithms to detect preeclampsia, hypertension, and intrauterine growth restriction. The user interface of the app was designed by the Maya midwives themselves. It is pictogram-driven and has audio instructions in the local Cachiquel Maya language. This enables use by end users of all literacy levels. Partner organization Wukukawuk built on existing relationships with government health services to create a care navigation program that went alongside the tech toolkit. So when a perinatal risk was identified, we could facilitate transfer to a health facility in a timely manner. Since Safe Natal began as a pilot program and a clinical trial 7 years ago, it has become the standard of care for midwife-led maternal health care. In the area of Guatemala that Safe Natal serves, before we started, they had one of the highest maternal mortality rates in the Western Hemisphere. It is now close to zero. This is such exciting success. One of the other big successes, in my view, of Safe Natal has been the invisibility of foreign team members following the co-design process, including myself. Safe Natal in Guatemala is entirely implemented by Wukukawuk staff and the midwives. I truly believe that we can rebalance the power dynamics of global health. And we've seen through this example that co-design can be a tool to help us do that. But it can't be just a buzzword. It has to be real. Otherwise, it becomes just another shiny new thing to leave behind in villages worldwide. I also believe that we can build and design equitable global health systems. But these will not be outlined in a World Health Organization toolkit or an international conference presentation or in a TED Talk by a white lady from Tennessee. I'm no savior. I'm not even Tennessee's own Dolly Parton, and I don't belong in the pilot seat of global health. Instead, equitable health systems will be built in, for, and by communities around the world. And I believe Codesign can be one tool to help make that happen. Thank you.